now let's jump to hemophilia. Okay, and how is it with hemophilia? So we're getting to coagulopathies, inherited, and hemophilia A, B, and C. And with C is rare and light. Only 1 out of 100,000 has it, and it's very light in a way. It's a decrease of factor 11. And where's the problem? It's on the chromosome 4. That's why 1-to-1 men and women get it. And typically these are descendants of Ashkenazi Jews, actually. Okay? And they have it in their families. It's very light, so it typically, you don't see spontaneous bleeds over here. Maybe epistaxis, that's it. When it comes to be serious, is during major surgeries or traumas. Otherwise, it's pretty nice hemophilia anyway. Okay. Compared to A and B, and A and B both are. This is factor 8, as we talked already or said many times. This is factor 9, and both are X-linked. X-linked. Okay. With hemophilia A, you have the incidence is 1 out of 5,000 males. Watch out, males. This one is 1 out of 30,000 males. So this is much rarer. But clinically, A and B are very similar because they have bleedings into the joints, they have deep bleeds into the muscles, and they have rebleeds. So I don't know, someone takes out your wisdom teeth. Sometimes they bleed right away longer, but in many cases the bleeding stops because immediate stoppage of bleeding is up to the thrombocytes and they're fine. But then they rebleed. 3 days later they can rebleed because they're not stabilized by the fibrin mesh. Okay? Let's be more specific with A, which is the most common. In case you'll see hemophila, you'll see hemophilia A. The problem is decreased factor 8. But how is it with the carriers, mothers, the carriers? Do they have some problems? Not at all. Why? Because they have 50% of the normal levels, and that is beautifully enough. Beautifully enough for the function of the coagulation cascade. If you have 50% drop, it's okay. Remember, there's a general rule about the amount of factors, all of them. Basically, we can say, if you have dropped to 20 to 30% of the normal level, that's maybe where you can, where the prolonged PTT, for example, starts, okay? But still, you don't have to bleed so much, okay? Only maybe the times is going to be... So, at 20-30%, you can have some light, not important problem, in a way, or only test-specific. And with factor 8, the severity comes when you drop to bit above 5%, okay? So typically, and those are only... With hemophilia A, again, imagine small boys with broken knees, with painful knees, okay? Swollen, painful knees, deformed knees. If you do an X-ray of the knee, it's really deformed, okay? So that's typical. If the boy, and I will on purpose say boy to fix it in your brains, if the boy has over 5% of factor 8, it's light hemophilia. They don't have any severe problems in a way. They typically, with this amount, when the child is born, you don't know he has hemophilia. You will notice after he will start to crawl and hit his knees, and that's when they start to bleed in it. Okay, so it's a light hemophilia, and guess what? If it's light hemophilia, it depends on the clinics. If they're not just bleeding just a bit, what can you give them as a therapy? Only desmopressin again. So you can really use desmopressin as for von Willebrand, as for hemophilia. You're going to just boost their factor 8 and von Willebrands, and you're going to protect them for some time. Okay, against bleeding. So it's for the lightest types, you can give just desmopressin. If it's below 5%, if it's between 1% and 5% of factor VIII, yeah, then you should typically you use doses of desmopressin. If this is not working, what do you use? You give the factor VIII. Fortunately, nowadays we can give factor VIII generated already, so we just supply it, resupply it. And typically, again, I will jump to both of them. We're resupplying factor VIII and also factor IX. This one is so rare and unimportant. I don't think that they're producing factor XI. So you give just plasma or whatever, full of all. Okay. So in this case, if they start to bleed, you give just fresh frozen plasma. Okay. But in these two cases, we have specific packs of factor VIII and von Willebrands and factor IX. Okay. So, but what was the problem of these boys in 80s? Obviously, they got except factor VIII, they got they got many bonuses to it, like HIV and whatever, because of course in that time, especially hepatitis C, also because we can test hepatitis C like since 80s. Before we didn't know about it, we couldn't test it. So basically, it's a view how you should look also on the patients which come to you. Okay, if they receive transfusion before 1980, watch out, they can have hepatitis C. But actually, now you would know, because typically if you have hepatitis C, it's already been 80, so that was 2000. And it needs how much? 20 years to like evolve into cirrhosis. So basically everyone who got in 70s hepatitis C now has already cirrhosis. So you would guess he could have a virus, okay? But why was this so bad in the US in that time? Many boys with hemophilia received HIV. Why? Because typically, I think in those times, or still, you got money for giving blood. So of course, obviously, who went for that? All the narcomans and whatever. They needed money, so they were giving blood. That was the way how to get money, and so it was a big problem. That's why, if someone is financially motivated, it's not good with the, let's say, quality of the blood. So anyways, you got the message. So now we can give them pure factor VIII. But what is the main problem today of the hemophilics, which are getting the factor VIII? It's artificially made, so allergies again. They're starting to have many allergies on that. Okay, so, but. And by the way, with transfusion itself, I'm sure you are all aware already, because the Mormons, and these which really don't want blood, there's something about it. Of course, you need blood. Of course, if you have severe anemia, you're dying, you need erythrocytes, okay? But I would look at it like, if you don't need it like 100%, don't give it, because although the blood can be beautifully like without any pathogens, whatever. What do we see typically when someone gets transfusion? What are you causing temporarily? What? Well, yeah, but I mean in terms of, let's say, if I will more specify it, or scenario, someone has a beginning cancer, okay, wherever. And this is what we typically see. Now he bleeds somewhere in GIT, so you give them transfusion. And all transfusions, in a way, it's not your blood, it's someone else, they are immunosuppressive. And you give them, and now you see metastasis everywhere. So watch out. It's sort of a immunosuppression. Transfusion is sort of a immunosuppression. Okay? I don't know how it's going to be in future. Maybe it will be cool to have your own pack somewhere, but your own packs of blood, and store it anywhere. But anyways, it's.
What they do in surgery now is that when the patient bleeds, they suck it and it goes filters through.
Of course. That's obviously, to having home stem cells producing my own blood and whatever, that would be cool. You know that, yeah. We don't have to go deep into this. It's going to be a huge business, definitely. It's going to be awesome business for someone. Anyways, factor H, still hemophilia A. Remember that, maybe that was enough. I think that was enough. Still B, I comment on B. What is special about B? As we talked about Ashkenazi Jews in the type C, B is what? It's the royal family. Queen Victoria had it, okay? Queen Victoria, and maybe she had a spontaneous mutation, I suppose, because she was the first one described. And she gave it to. She sent it to Russia because her children, they went to Russia, married this one, then to Prussia, then to Spain. Okay, so this type B hemophilia was it's called the royal family hemophilia. That's why it is so, let's say, famous. But first it was described, that's why you call it Christmas factor. There was a boy named Christmas, and I think in the US where they described it at first, like, I don't know, 80 years ago, I don't know when, but it doesn't matter. But still with A, and one thing, and important comment, watch out. 25% are new mutations. So basically, if you are healthy parents, you can have a child with hemophilia, okay? Or at least a carrier. Because they are, in 25% of cases, they're new mutations, okay? So although we all see it as the royal family and whatever, and that it's inherited, no, 25%, which is pretty common, okay? There are, let's say, 4 boys, hemophilic, one of them has a new mutation.
For B or for A?
For A, I think. But, I'm sorry, I mixed it together. For A. I think it's for A. That's the more common one, of course. So 25%, maybe it's whether, it doesn't matter how many percent, maybe it's counted together, I don't know. But it's definitely for A. Remember, if you're going to talk about hemophilia, you should always first imagine A. That's the most common one. 1 out of 5,000 men. Okay? So, A, B, C. A and B look just the same in clinics. Okay? Although, desmopressin you can use only for A, because that's factor 8. 9 factor, it won't work on factor 9. So these were inherited ones. And what about acquired ones? So if we talk about factors, always, you should see always the power plant on factors, and that's liver. So liver cirrhosis. Everyone who has liver problems has decreased everything, all the factors, except one factor. And I'm not talking about calcium and tissue factor, but all the other ones somehow come from liver. All the other ones, except 3 and 4 factor. But all the other ones come from liver. But if you have cirrhosis, and I told you during the lecture, there's one which will not be decreased in cirrhosis. And which one it is?
Is the one that produces the calcium?
No. It's produced by endothelial cells. And that is which one? No. Factor 8. Factor 8, again, remember I told you, factor 8 is produced by endothelial cells of the liver vessels, mainly. But all the other endothelial cells in your body are able also to produce factor 8. But the majority is produced in the liver, but not by hepatocytes, but by endothelial cells. So when you're failing with liver, your hepatocytes are destroyed. So all the other factors go down, but 8 can even go up during cirrhosis. It can be even increased. Okay. Remember I told you how did they find it? They wanted to cure hemophilia with a hepatocyte transplantation, and they found out they cannot. They can only cure it with liver transplantation because they give them also the endothelial cells of the donor. Okay? Yeah? So remember, factor 8 It's not decreased, it's actually increased. And this is an important differential diagnosis for DIC, because in DIC sometimes looks very similar in terms of tests and thrombocyte levels as liver disease. But if the factor VIII is decreased, it's rather DIC. If it's normal or higher, it's rather cirrhosis. Okay? One more thing, I told you about factor VII and its half-life, remember? And factor 7 and 5, they have the shortest lifespan. So basically, if someone starts to be ill on liver, at the moment when he starts to have prolonged, because there's the first drop of factor 7, so first the PT time is going to be prolonged, and later even PTT when all the factors will. So it actually tells you, hey, he's starting to fail with liver. Okay, when the PT starts to be increased. Okay, so that was liver. Connection with liver is what? I have to hurry up. Liver means vitamin K. You all understand that. 2, 7, 9, and 10. It blocks them. Remember, with vitamin K therapy, it could be not getting enough of vitamin K, or what? Malabsorption. Any cause of malabsorption, pancreatitis, whatever the causes, you can have decreased factor vitamin K and decrease these factors. Also, let's say all the broad spectrum antibiotics which kill your gut flora will decrease vitamin K, and you can bleed. Okay, that's vitamin K, and also warfarin, of course. On purpose, you're blocking vitamin K. I told you already, no time to go into it deep, but remember, some patients are really stable with INR. But if they have DVT, you give them warfarin, and it's you should keep it between 2 and 3. But some really go up and down. It depends on the gut flora. It depends on the stuff you eat. Okay. If you eat lots of cabbage, you're eating too much of vitamin K, you just kill the function of the warfarin. On the other side, if you take warfarin and then you take broad spectrum antibiotics, if you kill your gut flora, your INR can really go up and they can bleed. Okay, so watch out. It's not so simple with warfarin, and they should go for checkups for INR like twice a month. Everyone who's on that, okay? And heparin, as I told you, the advantage of heparin, of the big one, the high molecular weight heparin, is you use it in surgeries and in the hospital because you have antidote protamine. So before the surgery, you give them heparin, and at the end, you give them protamine, that they won't clot anywhere, okay? But if they're on high molecular weight heparin, you have to take care of it. You have to measure APTT and etc. If they're on fraxiparin, then you don't have to measure anything. You just give them a dose, and you can give the needles and the fraxiparin home, and they're going to sting themselves all the time, every day, and they're protected. Okay. Anyways, watch out with heparin, especially the big one is really allergenic, and you can end up with HIT. So do not underestimate HIT. It's more and more common. So these were the disorders, and still mixed disorders. Okay. So we already talked about them, because that means mixed means primary and secondary together are broken somehow. And what could you put here? Of course, von Willebrand's disease and many other. Okay, von Willebrand's you can put here too. What else? Liver diseases. Okay? Yeah, there too. And what about, and this is why I'm here now, DIC. This is very important. DIC, disseminated intravascular coagulation. Although it's coagulation, you should always imagine that they're bleeding. And the point is they're bleeding everywhere. As we were talking about in the beginning, over here you have combination of superficial and deep bleedings, because everything is consumed. First you form a thrombus, and then you immediately consume. With this, you consume thrombocytes as well as all the factors. So they bleed everywhere. What is debatable very much is if to use heparin or not. And there is a big fight between let's say, urgent medicine and hematologists. And the point is, on DIC, you should more look like a complication of some severe disease, like a complication of sepsis, or complication of amniotic fluid embolism, or something like this, of cancer. Okay, so there's something in your body, some serious disease, and it starts the DIC. And basically, DIC is the ticket out of this world in a way. Okay, so many people with severe diseases die on DIC, so they bleed out. Okay, and as there is this idea that first you form a thrombi and then first you consume everything. So that's why in 90s they started to give heparin first to if it's at the beginning, maybe it helps, we don't know exactly. But so first you want to stop the thrombus formation and that's why you're not consuming and that's why you're not maybe bleeding. But there are different schools. Some say we should use heparin, we should not. There's not a clear outcome. Maybe why it is because the etiology of what started the DIC are totally different. Okay, so in some cases it really helps, in some won't. You have to make. I'm sure a hematologist will go deeper into this with you. For me, the important message to you is remember everything is consumed and all the factors are down. And still one more thing, and that is you're forming a thrombi. So again, I'm reminding you, you're going to have hemolysis, and the magic word is, or 4 letters, is maha. Okay, maha. So if I will summarize it, all these diseases over here. So let's put it PT, PTT, thrombocytes, and erythrocytes. And let's put hemophilia, or Hemophilia A and B, von Willebrand's disease. Yeah, I don't know. Liver disease. Liver disease. Okay. Like this. It's better? Yeah. So von Willebrand's, hemophilia, von Willebrand's disease, liver diseases. Then I will put, what else? DIC, ITP, and TTPS. So, what do you think? In hemophilia, what about PT? Will it be prolonged? What do you think? It's the tennis outside, so it should be normal, yeah? What about PTT? Factor 8 or 9 decreased. This will be rather prolonged, okay? What about thrombocytes?
Normal.
If it's not a severe hemophilia and you didn't bleed it like 5 liters, okay? So it should be. What about erythrocytes? Normal, okay? What about von Willebrand's disease? What do you think? PT. What about PTT? Or in Europe we put this A over here. Whatever. It could be normal or prolonged. Why? Protecting the factor 8. Okay. Yeah. Thrombocytes should be normal. It's thrombocytopathy. And erythrocytes normal. Okay. What about liver diseases? I don't have factors, so PT will be increased PTT, increased thrombocytes. This is also questionable in a way, but you could put normal or decreased. Why? It depends how severe cirrhosis, for example, you have. But what does liver? What kidneys produce? What? Erythropoietin, liver, and other cells also, but mainly liver produce thrombopoietin. So if it's a really like almost dead liver, you're going to have decreased thrombocytes. And not only this, if you're having liver cirrhosis, then your spleen gets bigger, isn't it? So it can also there's an increased distraction in the spleen. Okay, so it can be decreased. And what about erythrocytes? Again, depends how big the cirrhosis is, but they should be normal. Okay, DIC. How is it DIC?
Use all the coagulation.
Yeah, of course. So prolonged. What about thrombocytes? Decreased. And what about erythrocytes? Why?
Because you bleed.
Maha. Very good. Maha. And you can bleed, of course, also. So. But Maha. But with the bleeding, watch out. To have decreased levels with the bleeding, it's always they have to dilute you with something. So if you bleed now and you didn't get any water, then concentration is going to be normal. Okay, so watch out for that. So ITP, how is it with ITP? So ITP means immune thrombocytopenia. So normal, decreased, normal. Very good. And what about TTP has? PT. Normal. Yeah, remember I told you. TBC. Platelets. Decreased. Why? Why decreased?
Distraction.
Okay. Yeah. Also over here, more you can put D-dimer. DIC. Yeah. DIC. D-dimers will be increased. Yeah, in the DIC. Because D-dimer, it tells you there is a coagulation cascade activated, and it went through fibrinolysis, and I have a D-dimer now. So these were the bleedings, and in 6 minutes, 4. Still very fast. Sorry, we don't have time on that, but with the Hemophiliac. Okay. So, thanks for watching, and don't forget to subscribe and ring that bell. And as always, check the description below for supplementary questions and other materials.